So we want to begin our conversation about neurotrauma with a clinical example that allow me to discuss with you some of the specifics around neurological exam and neurotrauma that are important for. So we have a 3-year-old found by the family in a pool of blood in his bedroom. He was taken to an outside hospital and then transferred to the University of Mississippi Medical Center for a presumed gunshot wound to the head. On his exam, he's a GCS of 7T, and I'll get into it, the specifics of what that means just in a second. His motor exam was 5, E, it means eyes, was 2, and his verbal was T, meaning that he was intubated. He does not open eyes, does not regard, does not follow commands. The pupils were 3 millimeters bilaterally, and then reactive and constricted down to 2 millimeters bilaterally, and there was no movement to stimulation. So the Glasgow Coma Scale is a measure that was created by Dr. Teasdale from Glasgow, Scotland, so that's why it's Glasgow. It's not Glasgow. And it's a measure that allows us to understand the severity of a brain injury and speak in a vernacular that allows an understanding amongst physicians. When I tell someone that this individual is a GCS of 7, then I have some sense of how the severity of their brain injury, irrespective of what the specifics of the exam are. So it's divided up into 3 components: eyes, verbal, and motor. So eye can be 1 to 4. So 1 means that you don't do anything. 2 means that you open your eyes to stimulation. 3 is open your eyes to sound. And 4 is that your eyes are open spontaneously. Your verbal response is, again, 1 to 5. 1 meaning that you make no sound. For most institutions, you also receive a 1 if you are intubated. 2 means that you're making sounds, but they're incoherent. 3 is that you're saying words, but they don't make sense. 4 is that you're making coherent phrases, but you're confused. And then 5 is that you're oriented and have clear speech. Your motor exam is 1 to 6. 1 means that you're not moving. 2 means that you're extensor posturing. 3 is abnormal flexion. 4 is what we call normal flexion or withdrawing, meaning that I stimulate you and you withdraw your body part from that stimulus, trying to remove yourself from the pain. 5 is localizing, meaning that you will grab and try to remove a stimulus from your body. And then 6 is you are obeying commands. And we provide you that number. You get the highest number that according to your exam. So for instance, if you in one side of your body are localizing or flexing, but the other side you're following commands, then you will get a 6 over a 4 or 5. And then we sum up those numbers and gives us a grade of traumatic brain injury, with mild being 13 to 15, moderate 9 to 12, and then severe is 3 to 8. And a critical threshold is 8, meaning that a person with a GCS of 8 or less is suffering from, has a severe traumatic brain injury and is clinically in a coma. And a GCS can be affected by more than just the fact that you've had a brain injury, but it could also be iatrogenic. So a person who is a GCS of 7 could be a GCS of 7 because we've given them lots of sedating meds, or a GCS of 7 because they've been paralyzed and they're not completely worn off that paralytic for intubation, for example. And so it's important when assessing someone's neurological status to understand what medications they've received, what other things are impacting their exam before just simply stating, oh, this person's a GCS of 6 and it is a severe traumatic brain injury. So what I'm showing here is the patient's initial CAT scan. It's a non-contrasted head CT. Head CT means head computed tomography. It's a measure of tissue density, and so things that are very dense show up very bright. Things that are less dense, such as air or water, show up as dark, and so the brain tends to be sort of in the middle. It's more like water than it is bone. So bone is very dense, metal is very dense, water and air are relatively non-dense, and so they show up much darker. And so what this shows is on the patient's right side, which on this scan looks like it's on the left. Again, you have to remember the axial images on the left are flipped, and you're looking at the patient from their feet toward their head, and so the right side of the scan is the patient's left side, and the left side of the scan is the patient's right side. And then similarly on the right is a coronal view, which the patient's, it's like you're looking at the patient. So the right side is the patient's left, and the left side is the patient's right. And what it shows here is there's what appears to be an entry type of wound on the patient's right side with a crossing into the patient's left side that crosses across the brain with multiple areas of hyperdensity. Some of that is bone, some of that is likely bullet fragment, and some of that is blood. And in layman's view of gunshot wounds to the head, many people think that this is not a survivable injury. But 4 years later, we see this kid who comes back to clinic doing actually relatively well. Children have a remarkable ability to recover. Their neurosystem has a remarkable amount of plasticity, and so they're able to create new neurological networks to accommodate for things that have been lost. And so particularly in younger children and in young adults, we are very aggressive in the management of their injuries because there's a good chance for good recovery in the long term.